Thank you for joining Cancer Support Community Atlanta for this program. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. We invite you to sign up for our newsletter to stay connected to all future programs.
In these clinical scenarios, I'm going to discuss two recent trials that have influenced how I personally manage my melanoma patients. So first, when we talk about stages, I think it's important to just state that every cancer, whatever it is going to have a stage. The stage is the way we communicate with each other as physicians and how we communicate to our patients about the aggressiveness of a cancer. The three major groups of stages are the cancer can be either contained, it can spread locally or distantly. And that is the information provided in a stage. Melanoma stages are going to be divided into 1, 2, 3, and 4. Stage 1 and 2 are localized melanoma. This is 90% of melanomas. So melanoma is very fortunate in that the majority of the cancers present early stage. And even within that localized presentation, stage 1, which is the earliest stage, is the most common stage of presentation. The way we characterize stage 1 and 2 melanomas is either by depth or ulceration. Those are the two factors that help us divide up stage 1 and 2. And you can see in this picture that melanoma starts in the epidermis here, and then in the most superficial layer of the skin, and then starts to dive down into the fat. As it gets into the fat, it has an increased risk of growing into blood vessels and lymphatic vessels. And that's when the cancer has an increased risk of spreading. So hopefully this picture just helps you understand how melanoma grows and how the increased depth increases your risk of distant disease. Stage 3 represents spread to regional and surrounding lymph nodes. This picture shows a melanoma of a forearm, and you can see here that the picture is demonstrating spread to lymphatics. So I think this is an important point that you have lymph nodes all over the place, all over your body. And oftentimes we as clinicians and patients are surprised where melanoma spreads into which lymph nodes. But here you can see that there are lymph nodes in the elbow that the cancer can spread to. So that would represent stage 3 melanoma. Stage 4 is the most advanced kind of melanoma, and it's spread to distant organs. So only 5% of melanomas present that way. Remember, the majority of melanomas presenting very early. But the other ways patients can get to stage 4 is that they present with a different stage, and then the cancer in a certain amount of time, unfortunately, spreads to distant organs. This picture shows a PET scan, which is an imaging modality we do of a disease that has spread to distant organs. So now that we've reviewed the stages, I want to go over treatment of melanoma based on stage. So for stage 1, it's very straightforward. We do a wide local excision with 1 or 2 centimeter margins. You can see here that in the center of this picture is the tumor, and we mark out in all areas 1 centimeter around the tumor, or 2 centimeters, depending on the depth, and then create an elliptical incision, usually to allow for a tension-free closure. And that's why such a small area ends up presenting with such a big incision. Patients are always surprised at how big the incisions are for these diseases. So stage 1, you do a certain amount of margins and do a resection. Lymph node sampling is considered for certain depths of stage 1 melanoma when the risk of lymph node disease approaches 5 to 10%. I'm going to move on now to stage 2 melanomas. We still always do wide local excisions and we do lymph node sampling is definitely recommended in this surgery for treatment of stage 2. Now, I just want to talk a little bit more about the sentinel lymph node biopsy, which is the most common surgery we do in our office. This is indicated in stage 1 and stage 2 patients, and it helps detect small areas of disease in the surrounding regional lymph nodes, and then helps accurately stage the patient to stage 3. So somebody can start with stage 1 or 2 and move to stage 3 based on the sentinel lymph node procedure. The way we do this surgery is here you can see that this is our patient's melanoma. And so 2 dyes are injected into the area of the tumor. It's a radioactive dye injected by a radiologist and a blue dye injected by the surgical team. And these dyes help us map out the first draining lymph nodes of the tumor. In the surgery, we use this Geiger counter, which is a probe, to help find the nodes that have the radioactive dye, and also the blue nodes that have the blue dye. We remove the nodes and also remove the wide local excision around the tumor and send both of those to pathology. And in that way, they better analyze the exact extent of disease for that patient. So for stage 3, you could either present with lymph node disease or surgically detected lymph node disease. For those patients, we recommend the majority of them surgery and systemic therapy. And the 2 major classes of systemic therapy are immunotherapy and targeted therapy. Both have excellent outcomes for melanoma patients. Stage 4 disease, which we showed before, is disease to distant organs, would be systemic therapy. And for immunotherapy, they have 2 agents, not just 1. We call it dual agent immunotherapy for these patients. And again, targeted therapy is a great treatment also for stage 4 melanoma patients. Sometimes we do surgery in stage 4 melanoma, but usually we reserve the systemic therapy first. So now I'm going to transition to clinical scenarios. The first is a 55-year-old man who presented with an abnormal nevus on his arm. This is the picture of what this mole looked like on his arm. It was irregular and dark and had been growing. His primary care doctor decided to perform a biopsy. This is a shave biopsy. They use a knife to basically remove the most superficial layer of this disease. And they sent this to pathology. And this is the report. And you can see these are words we use. It was not ulcerated, but it was a melanoma. And the depth, which is the most important factor, was 1.2 millimeters. Okay, so that usually generates a referral to a surgical oncologist. So they saw us and we took them to surgery. We did a 1 centimeter margin around the tumor and also did this sentinel lymph node procedure. This was done under general anesthesia. So this is the final pathology, and it shows that there was no residual disease in the wide local excision and the nodes were negative for metastatic disease. So it's good news, a good report for our patient. And their final stage after surgery is a stage 1B melanoma. So what is their next treatment step? What is their risk of recurrence? What is their overall survival? And what I'm going to get to is how should he be followed? So treatment, again, for surgery, for stage 1 melanoma, surgery alone. So we did the wide excision in the sentinel node. The risk of recurrence is excellent, less than 10% at 3 years, and 95% of patients are alive at 5 years. So very good outcomes for our stage 1 cancers. So the next question that patients are always going to ask us is, what happens next? How often should I be followed? We call this surveillance. It's defined as a close watch over someone or something. And for cancer patients, it's monitoring of patients either during or following treatment. So this would be a question that they ask: how frequently do I return? And what are you going to be doing during those treatments, during those follow-ups? Unfortunately, for many cancers, these schedules are very poorly defined. The guidelines provide very wide ranges, and the data isn't clear if increased frequency of appointments or if imaging improves outcomes. So now I just want to, with that question in mind, I want to talk a little bit about melanoma and the incidence of melanoma, and why this is a real problem in my specific disease treatment. So this is a good problem we have, which is really exciting because basically melanoma patients are living a very long time now. So the incidence in the US has recently stabilized of diagnosis of new cases of melanoma after very prolonged increased trends. Though in 2022, it's a projection of approximately 100,000 new cases of melanoma will be diagnosed. 90% of those, remember, are going to be stage 1 and stage 2. And the mortality, meaning the death rate of these melanomas, continues to decrease. And we have seen some sharp decreases in how many patients die of melanoma. So in general, we have a growing number of patients that are asking us this question: how often do I need to follow up? And what is this follow-up doing for me? This picture shows these trends. You can see this stage 1 and 2 patients are living, more than 95% of them are going to be alive in 10 years. For stage 3, that survival is less, but still pretty good, close to 80%. And what we're most proud of is these stage 4 patients. You see this increased trend right here. That has been an amazing thing. And these slides this data is old. This year is a big cancer registry that updates survival statistics basically every decade. But I would expect that this trend to continue to increase as far as survival for our stage 4 patients. So the take-home point is we need evidence-based guidelines for surveillance in our growing number of alive melanoma patients. I really like this trial, and I really liked this paper. It was, it's called MELFO, and it was a randomized controlled trial performed in Europe. And what they did was they compared a reduced evaluation schedule versus the standard follow-up schedule for 3 years after diagnosis. And the one great thing about this study that I think is most important is it really evaluated well-being in addition to recurrences and deaths of early stage melanoma patients. So they were really looking at things that determined quality of life. This is the way they set it up. Here on the left is the conventional follow-up schedule. This is our guy, stage 1B. And you can see in the conventional schedule, he was scheduled to follow up 4 times the first year, 3 times the second year, and 2 times every year afterwards for a total of 5 years. Their follow-up schedule, this is the experimental, showed him 1 time every year for up to 5 years. So, and then obviously they did the same thing for 2A, 2B, 2C with different follow-up schedules depending on how concerned they were about recurrence. The results of this study looked at well-being index and oncologic outcomes. And you can see that in the well-being index, the level of anxiety, cancer worry, and mental health related quality of life were worse at 1 year for the patients that had an increased frequency of follow-up. At 3 years, which was helpful for me to think about, that patients had very similar quality of life, regardless of their follow-up schedule. But that was the one difference at 1 year. Recurrences and new melanomas were the same, whether you followed up 4 times a year or 1 time a year. And the patient, the one thing that take-home point that's consistent in all studies is that patients diagnose their recurrences themselves. a lot of times the patients would bring to the attention of the physician, hey, take a look at this. This is different. So I always try to empower my patients to know that they are the ones that are most likely going to diagnose their recurrence or their metastasis. So to please feel comfortable in our relationship to bring up things when they have these concerns. The deaths, there was no difference in disease-free survival, whether you had the control follow-up schedule or the experimental. And obviously there was a significant reduction in cost, both to the patient and to insurance, to whatever factor, to the institution of this reduced follow-up schedule. So in conclusion, reduced stage adjusted surveillance is safe, appropriate, and cost-effective alternative for staging for stage 1B to 2C melanomas. Okay. So I have one more clinical scenario. This is a 65-year-old man who presented with this concerning abnormal mole, and the pathology after its biopsy was a 4.2 millimeter deep ulcerated melanoma. The patient went on to receive a wide local excision with 2 centimeter margins and a sentinel lymph node biopsy. Now, there was no residual melanoma in the wide local excision and no metastatic disease in the sentinel nodes. So we all rejoiced and celebrated this fact. Now, what is this? The patient wants to know what comes next. So even though we stage all these patients and we follow specific guidelines based on the stage, as clinicians, we have always noticed this pitfall in our melanoma staging, that these stage 2C patients do poorly and their stage is not reflective of that, meaning stage 3A patients do better. So you can have lymph node metastatic disease, and you can see here, this stage 3A patient has a decreased risk of recurrence and a much better, a greater than 10% improvement in survival versus my stage 2C melanoma patient. So these almost half of these stage 2C melanoma patients are going to recur in 2 years, and their survival is 82% in 5 years. So that's concerning for our patient population. And unfortunately, up until very recently, we didn't do anything except watch and wait for them. We surveilled them and waited for them to recur. So recently, there was a clinical trial that said, would stage 2 melanoma patients benefit from systemic therapy? We know they do worse, but would they actually do better if we gave them systemic therapy? And that systemic therapy was immunotherapy, single agent, and it was tested in stage 2B and 2C melanoma patients versus placebo. So if there are any patients out there from our center or any other center that enrolled in this clinical trial, just want to thank you personally for contributing to this really important trial. You can see here that those patients either got saline, which is the placebo, or they received immunotherapy. And when they compared these two, they saw that the risk of recurrence or death if you got immunotherapy was 15% versus placebo, it was 24%. Obviously, because they were receiving a drug, the adverse events were much higher if they received pembrolizumab, and about 61% of patients completed the therapy. Now, a criticism of the trial is that the follow-up is short. It's just shy of 2 years, but I do think that the data was very compelling. What we want to see in these patients is that we're affecting distant recurrence and death. And you can see here that even though death was not significant, distant recurrence was. So in the immunotherapy group, they had significantly less disease that spread to lung, liver, brain when the patients received immunotherapy, only 6% versus 12% in the placebo group. So in conclusion, we can say that stage 2B and C melanoma patients show this decreased risk of disease distantly, and it should be a conversation if immunotherapy is the right thing for them. So in summary, this is my last slide. The majority of melanomas present early and are treated with surgery alone and have excellent outcomes. Because we have this trend in increased diagnosis and decreased deaths, we have more patients in follow-up. Surveillance for these patients should utilize a data-driven approach, and well-being, quality of life, and cost need to be considered as important outcomes in addition to their oncologic outcomes. Decreased surveillance in early stage patients is safe. For stage 2B and C melanoma, we should now consider these patients for adjuvant single agent immunotherapy. So that was my last slide, and I'm happy to take some questions.
Thank you, Dr. Kounalakis. That was a wonderful presentation, and we have had some questions come in. So let me go ahead and get to those. A lot of really positive and reassuring information here. I have a family history of melanoma, so it's nice to hear, especially the data you presented about stage 4 increasing survival. One person asked, I have squamous cancer on my ankle, not having it removed for almost a month. Is that all right?
Yes. You know, in addition to treatment, so there are studies that look at treatment of care and timelines of care for when after a biopsy to when you should have a surgical resection or treatment. For cancer, usually, believe it or not, and I know it's very disconcerting to patients, but most studies show even up to 3 months is okay, doesn't affect oncologic outcomes. Obviously, every patient's different. And if there's pain, or if there's wound issues, or there's something like that, you know, you should feel comfortable communicating that with your physician. And here at Northside, we do try really hard to get people into surgery within a month, and hopefully even sooner than that. But the studies have shown that up to a significant amount of time is actually safe for oncologic outcomes.
Wonderful. All right. And how does a Clark scale for malignant melanoma relate to staging of the cancer?
Yeah, so Clark's levels, I sort of wish that Clark's levels didn't even exist because it creates so much confusion for our patients. The short answer is Clark's level does not influence stage. It's not in the staging at all. It's really something that dermatopathologists look at as kind of the type of growth pattern and depth into specific tissue planes. And that's how this Clark level is described. I don't use it when I'm talking to my patients. It's definitely not incorporated in the staging. I think unless you're a dermatopathologist, it's not very relevant to you as a patient. Emily, are there any other questions? I think you're muted. Oh,
yeah, sorry, I was muted asking. When you have had a melanoma in 3 different locations on the body, is there a different follow-up schedule recommended?
I'm sorry, say that again. If you have
melanoma in 3 different locations, is there a different follow-up schedule?
Well, so I'm not sure if that's 3 new melanomas or if that's melanoma that has spread to multiple places. If it is melanoma that has spread to different areas, you are not, you weren't included in that study. So that is specific towards your medical oncologist. If you have had 3 different types of melanomas, we call them 3 primary melanomas, that it's not that one cancer has spread to different organs, but you've had 3 separate moles or pigmented areas, all of which represent new primary melanomas. That is rare. So your dermatologist usually, those patients were not included in that study either. Your dermatologist or skin cancer specialist, it probably is going to want to follow you more frequently. Unfortunately, we still don't have great data for how often that specific cohort of patients should be followed. But I can tell you it'll be more than 1 year for sure, one time a year.
They did say yes, 3 new types of melanoma.
Yeah. So most people with that usually do have lifelong surveillance, and usually are seen 2 to 3 times a year, but there is variability in that.
All right, and we have a few more questions coming in. Just to reminder for everybody, if you do have a question, feel free to enter that in the chat box at the bottom of your screen. These are some great questions coming in. I lost 1/4 of one ear from squamous, difficult wearing hearing aids, etc. Should I consider plastic surgery, or is there a better option?
For the, and I hate answering very specific questions, but I think, there are some good plastic surgeries that help you reconstruct an ear that will help with your hearing aids, which I know is a really big problem, that and wearing glasses when you lose a good portion of your ear. So yes, I think that would be the easiest way to reconstruct. If you're not a candidate for surgery, then you should probably reach out to whoever is prescribing your hearing aids and see if there's different ways that you can affix them. But there are definitely reconstructive options possible. There's even prosthetics for ears that sometimes are helpful depending on how much of your ear has been removed.
Thank you. And I'm getting some comments about how helpful this information is for people who've been diagnosed. And I did want to take a minute to let everybody know that we do offer a melanoma support group here at Cancer Support Community. It will meet next Wednesday, July 13th at 2 o'clock. And it is both virtual and in person. And feel free to email me. I'll put my information in the chat box if you're interested in joining that group. It seems like a specific question that I'll ask. Had in situ left forearm excision of melanoma in 2009. Is imaging for skin assessment now more available and appropriate for detecting new sites of melanoma? This is very anxiety provoking, even to think that they might miss a spot.
I'm sorry, imaging, let me see.
Is imaging now for skin assessment more available / appropriate?
Yeah, so let me just back up. If you had in situ, you did not have an invasive disease, so your outcome is even better than anybody I talked about here. Should be seeing a dermatologist. As far as imaging, we would never do PET scans or chest x-rays or CT scans for somebody like that. Imaging that may be considered our mole mapping, which different dermatologists do. We don't do that in our clinic, but certain dermatologists do that. I'm not familiar with the data for that, but that is an indication if patients request it, and certain places do. It's called mapping of all your moles with pictures. That would be the only imaging I would consider for a precancer melanoma in situ. But I do know how anxiety provoking going to the dermatologist is when you have that history.
I did have someone ask if this presentation will be available. Yes, we are recording, and it will be posted on the CSC website. And I will also share that with you, Dr. Kounalakis, once that's ready, if you want to share that with anyone as well. Another question, what is the most common type of skin cancer?
Right, so the most common is basal cell, and that is very treatable and does rarely influences how long you live. And it's treated with surgery greater than 90% of the time.
We have somebody say they have basal cell squamous. How serious is that?
So basal cell squamous would mean you have two types, because there's a squamous cell cancer and a basal cell cancer. Sometimes we have collision tumors where there's two types of skin cancers in one area of disease. Either way, these are usually very, very amenable to treatment, and surgical resection is again, greater than 95% of the time, the only need for treatment for those rarely spreads.
Wonderful. I will give a few more minutes for any more questions. We can go on to the information about CSC.
Okay.
Thank you. So this is just a little information about Cancer Support Community Atlanta. Like I said at the beginning of this program, I'm the program director, Emily Brown. We are the local network partner of the largest provider of oncology support programs worldwide. In Atlanta, we are very proud to be affiliated with Northside Hospital for over 20 years. We offer a variety of programs and classes to support cancer survivors and caregivers, and that includes our melanoma support group that I mentioned earlier that meets every month, and it will meet next Wednesday at 2 o'clock. And if you'd like to join the melanoma support group, just email me at emily@cscatlanta.org. I'd be happy to add you, or if you are a support person of someone with melanoma, we also have a caregiver support group called our Family and Friends group. Let me know if you'd like to join that as well. All of our programs are offered by led by licensed professionals and evidence-based, and are free of charge. Free to anyone. You don't have to have received treatment at Northside. It does not matter where you get your treatment. More questions coming in. What does malignant melanoma in situ mean?
Yeah, I don't see that one. Regression. Malignant melanoma in situ? Is that what you said?
I think so. I think they just left the NT
So
off.
it wouldn't be malignant. It would be melanoma in situ. And again, that's a pre-cancer. If somebody's saying you have malignant melanoma, it wouldn't be followed by in situ. Malignant melanoma would mean that you have invasive disease, whereas melanoma in situ would mean it's a pre-cancer.
If you have a regression in melanoma, does it have any bearing in prognosis?
So that's a really interesting question that I don't think we have figured out. I think that the general concession is that regressed melanomas or regression in melanoma, and all of these findings are really findings under the microscope that a pathologist detects. So not something that's really clinically evident as often. You know, that people think it probably does better, but the studies aren't very clear. If you have a completely regressed melanoma lesion, we usually just remove it and don't do further treatment. But if you have regression and invasion, we treat it based on the invasive component and not on the regression. Hopefully that answers your question.
Another question, have the genes for melanoma been mapped?
So there's no genetic mutation specifically associated with melanoma, like a congenital. There are some different high risk genetic syndromes, but there's not a specific mutation. I guess I'm not sure what that question is. Yeah, there's one specific genetic syndrome that people test for if you have a history of pancreatic cancer and if you have multiple invasive melanomas, usually 3. I have to remember what that is, but I'm sorry, I'm blanking off the top of my head, but there's one genetic mutation, but all melanomas, that specific mutation is incredibly rare, and there isn't a specific mutation associated with all melanomas, if that's helpful.
What is your recommendation for anyone with maybe a family history or just for the general public as far as seeing a dermatologist or getting screened?
That's a very big question, just so you know, and a very controversial one. So, and I'm just trying to present the data. The US Preventive Task Force that tells us when to get mammograms, when to get prostate screening, actually does not recommend skin screening guidelines because they haven't found that the data shows it improves how long you live with melanoma. So that's something that I think I have to just state before I give some common sense approaches. I think that patients who should get screened, the highest risk of when you would be diagnosed with a melanoma would be if you're immunocompromised. Those patients should always be seeing a dermatologist because their risk is so high of getting a melanoma. And other risk factors would be if you're greater than 65, Caucasian, have really fair skin, have a history of significant sunburns, blistering sunburns, have done tanning beds. Those are all high-risk features associated with getting a melanoma. Of course, there's other skin cancers that people can be detected, but because those do so well, it's hard to say that getting increased screening again is going to improve how long you live. I definitely recommend it if you come from a family that a lot of people have had skin cancer. If you have a first degree relative with skin cancer and you fit that profile of being very fair and have increased sun exposure, blistering sunburns. But it's hard for me to say when to start or exactly the amount of benefit you derive specifically from it.
Thank you. That's very interesting information, but good information for everyone to know.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.